Welcome, everyone, to the Heart Rhythm Society's monthly wrap-up in collaboration with the EP Edge. This is keeping you informed with our field's latest science. Joining me this morning is Dr. Niraj Sharma, creator of EP Edge. Niraj, welcome, and thank you again for this important collaboration.
Thank you, Mike. Pleasure to be here again. This is our second issue of this collaborative effort that HRS and EP Journal Watch is doing together.
Dr. Sharma has distilled a bunch of recent stuff, and it's good to have a human brain kind of pick and choose this very interesting potpourri. We got a lot to get through. So let's jump into it. The InEurHeart trial. This is European Heart Journal trial. Niraj, admittedly, this is not usually on my rotation, so kudos to look and find this. A great trial looking at AI and VT. What's it all about?
Right. So, we actually have two randomized trials to talk about today. InEurHeart, we're going to go first and then followed by the opinion trial. But a little step back, just to kind of give you a perspective of what EP Journal Watch did over the last 5 issues. We actually analyzed 49 trials. And out of those 49 trials, 7 were randomized, and the others were like a potpourri of observational data or meta-analysis or translational research. So out of the 49 trials, 7 were randomized. Out of those 7, we chose these 2 because I think they have some sort of a practical input as to what we do and what the future holds. InEurHeart, I think, is probably, in my opinion, one of the better randomized trials that came out over the last month or 2 months. So what was this InEurHeart trial? So this was a trial that was published February 2026 in the European Heart Journal. The trial is actually a CT guided versus conventional catheter ablation for ventricular tachycardia. And the more I read into this trial, the more relevant it becomes with our current state of affairs as we move from more, less electrophysiology, more anatomical ablation, similar to what we've all seen with pulse field ablation. But this is kind of similar along those lines where we're kind of moving away from electrophysiology and moving more towards anatomically guided ablation. But okay, so this trial was a investigator-initiated trial, multi-center, open label, and it was a 1-to-1 randomization for superiority. And the key point here is, the usual trials we have is superiority in terms of efficacy, but this trial, the superiority was for procedure time. So this was a European trial, 14 centers in 4 countries. They enrolled 113 patients with prior myocardial infarction and significant VT. Let me tell you how they quantified significant VT. Equal to or more than 3 VT episodes treated with ATP, greater than one or more appropriate AICD shock, sustained VT below the ICD detection rate documented by ECG or monitor, and sustained VT on a 12-lead EKG in the absence of an ICD. So those were the inclusion criteria, pretty robust inclusion criteria. And there were 2 important exclusion criteria. So patients should not have had a prior VT ablation, and the other one was a significant contrast allergy. The other ones were actually common sense stuff. If you had an LV thrombus or a mechanical valve, if you had polymorphic VT or VF, they were all excluded. A recent acute coronary syndrome within 30 days also warranted exclusion along with active ischemia. So this was the inclusion and exclusion criteria. The trial major hub was the CHU Bordeaux group. They had funding from EIT, I'm not really familiar with that, health grant from EU, and the French ANR. grant. And although these were the funders, they had no role in the design, conduct, analysis, or the decision to publish. So they were pretty much hands off. We can talk about disclosures at some point later on, but let's just keep on going with the trial. So what they did was they enrolled 113 patients, predominantly men, 91%. Ejection fraction mean was about 35%. And interestingly, about 39% had a history of electrical storm. About 43% roughly were on amiodarone. Men predominated, women were only 8.8%. So that's probably one of the limiting factors of this trial. They did a 1-to-1 randomization. Once they were randomized, pre-randomization, they had a CT scan done. So the thought was, well, we have to do a CT scan essentially to rule out a LV thrombus. CT scan was just by a conventional scanner. There was nothing sophisticated about the CT scanner itself, but the way the contrast was given was in a biphasic fashion to image both the LV and the RV together. So there was a certain protocol that they followed, a rapid injection followed by a slower infusion. So there was a special protocol for contrast. Once the images were obtained, they used this proprietary software called InEurHeart. And what the InEurHeart software did, it helped with segmentation of the CT images. The actual assessment of the images were done by two very experienced, more than 10 years experience, physicians who were capable of looking at CT scans. So the InEurHeart software did help with segmentation, but did not come up with an actual interpretation of the CT scan. So that's how the trial was done.
And so they randomized 1-to-1 people that got this imaging guided, the AI based software. What was the time reduction? How much time did this save?
So where does the time saving come from, right? You would think, well, the time saving came from maybe reduced ablation time, or was it the mapping time? So really, it just came from mapping. In the CT guided arm, there was no use of high density mapping catheters, so maybe a cost saving effect there. There was no mapping involved. They went straight with the anatomic interpretation of the isthmus. The isthmus itself was the way they defined it was an area of myocardial thickness within a thin area. The thin meaning scar, and then you've got these tracts or channels which are thicker than the scar area. So those were the areas that they were focusing on ablating. So the reduction in time was more to do with no mapping and less to do with the ablation. In fact, there was more ablation carried out in the CT arm. So time for RF ablation was more in the CT arm.
Got it. And the outcomes. So if we just take the mapping out of the equation, use this InEurHeart software, I worry about, are they going to really, they're just blindly anatomically following something. Is it going to work as well as what we're used to? But they found no difference in outcomes, right?
CT guided arm, they still had inducible VT in 25%. So they had to switch over in those 25% to a conventional approach.
And I think we need to mention that, I mean, the harsh reality is, Niraj, I don't know about your lab, but this is our worst procedure. Let's face it. A VT ablation has perhaps our highest recurrence rates, our worst outcomes, and our lowest success rates of anything we do. So it's nice to see some different strategy to approach this. As you mentioned, we should disclose that some of the authors had financial interest in this experimental arm, which may introduce bias. But I mean, let's face it, the decision to do VT, a lot of it has to do with how long these things take.
Right.
So
Right.
how long was the one versus the other?
Right. So in the intention to treat arm, in the CT guided arm, it took 120 minutes. So about 2 hours. And in the conventional arm, their usual 3D mapping, etc., it was approximately 150 minutes. So to be exact, it was 149 minutes. So, and this is on the intention to treat. But if you look at per protocol, it was 107 minutes in the CT guided and 149 in the conventional. So in the intention to treat, it was a 19% reduction in time. And in the per protocol is a 28%. So I think when you look at time, and you're right, currently VT ablation can go on for hours, right? And then you've got a sick patient as well. And then if you're doing the conventional approach, there might be you might be inducing VT, and then the hemodynamic instability that goes with that. So there's big pros for having an anatomical approach, at least first, to guide you. And if it's successful, no further induction, then that's it. And then if there is, then you can switch over to your conventional arm. So
when this comes out commercially available, you're going to put it in your lab?
I think so. I think it won't be across the board, but
right.
It would be for people or patients that are hemodynamically unstable. And I got to point this out that the trial included, of course, just ischemic cardiomyopathy or ischemic VT. This does not apply to our non-ischemic population. So, yeah, and you did mention about the disclosure. Of course, disclosure are important. Some of the authors actually had shares in the InEurHeart organization. So you just have to keep that in the back of your mind when you look at this trial.
So this is the InEurHeart trial, European Heart Journal. Niraj, thanks for picking this one out. Let's talk about the other randomized trial that EPEdge chose, the opinion trial. Again, European Heart Journal, valve patients randomized to left atrial surgical closure during their surgery or not. Pretty straightforward.
Yeah.
Tell us about this trial.
So this trial was initially presented at the European Society of Cardiology meeting in Madrid, August of last year, but just published in the same journal, European Heart Journal, in May of this year. The thought, I believe, in this trial was, why don't we take patients who do not have A-Fib but have structural changes that would predispose them to A-Fib, and then proactively take care of the appendage? So that was the thought and the concept. And we know patients who have significant valve disease, significant left atrial enlargement, that they are at high risk for both A-Fib in the future and also post-op A-Fib. The opinion trial was a Chinese trial. There were 3 centers in Beijing, China, but only one of the 3 centers did majority of the enrollment and procedures. The other 2 were really minor players. So in the trial, they enrolled a huge number of patients, more than 2,000 patients, and it was a 1-to-1 randomization, so roughly 1,000 patients in each of the arms. The arms were, conventional valve surgery. The valve surgery was aortic and mitral, and about 25% of patients who went for valve surgery also had bypass surgery carried out. So it wasn't a pure mix. So it's a 1-to-1 randomization. Majority of patients, again here, Mike, got mechanical valves. So that's another confounding factor that we'll talk about, mechanical valves, and they were put on warfarin. So there was a 1-to-1 randomization. The patients that were randomized to left atrial appendage exclusion had the occlusion carried out with an amputation. So it was a standard protocol.
There's a great video on that too. If you click on that link, they show a nice closure. Right.
Actually they do and they actually talk about the stump, etc. So the primary endpoint of this trial was ischemic stroke, They didn't really look at atrial fibrillation burden, etc.
I think the important characteristic that I found in the supplements is about 50% of these patients were on warfarin. I mean, a lot of them were on lifelong warfarin. And so the question is, why would you want to close the appendage if they have to be on warfarin anyway?
I know that was a big confounding factor in this trial. So that's, it really does change your outcomes based on the fact that they were already on warfarin. And another interesting tidbit was when they did the statistical analysis, they felt that there would be a 40% reduction in ischemic strokes if you had a left atrial appendage occlusion carried out, which was I thought a very high number, and then based on the episodes that occurred, which was only 17%, this trial too was underpowered to look at that difference. There was another big limitation of this trial, but nonetheless, the trial showed that there was no difference between the two arms.
So another neutral trial for surgical left atrial appendage ligation. Do you feel like there's a role? Are you telling your surgeons, based on what we have thus far, the sum of the data, should we be asking our surgeons to snip off the appendage?
Yeah, snipping of the appendage doesn't really add much time to the procedure. So, and, with minimal complication risk. Now, I know the appendage does have biochemical and electrophysiological properties, and mechanical too. So taking off an appendage without really solid background, I think at this point, it's inconclusive that we should suggest that, and particularly in patients who don't have A-Fib. If they do, they should. But if they don't, I think it's still at this point inconclusive. And even prior to the opinion trial, there were actually 2 or 3 other trials that were done. That too the results were not conclusive. So I think this trial doesn't really add much to what we already have.
But it is very large, very randomized, 98% follow-up. So I think it's sort of the neutral nail in the coffin for this in terms of all comers. And maybe we should be more selective in who we ask or in who we subject this to.
Right.
Great trials.
Yeah, there's one more point I want to make, though. There is a trial that we should be looking out for. It's called the LEAPS trial, LEAAPS. And this trial is much, much larger. It's using the clip, and it's the follow-up is much longer as well, for 5 years. So I think that trial should be a trial that hopefully will put all this to rest in patients who don't have established AF.
The LEAPS trial.
Yeah.
I'll look out for it.
Yeah.
Wonderful randomized trials. Journals, again, not on our rotations usually. Niraj, you ready for rapid fire?
Yep, I am ready. So,
okay.
What do we have for rapid fire?
Cavioli. What in the heck is a cavioli? It's not a ravioli. Cavioli in the sinus node, Jack EP. What's this all about?
So this is one of our translational papers, and I too had never heard of what cavioli is. I had to kind of do a little bit of reading on this, but it's a really, really good trial, and I thought it'll be good for us all to know about how deep electrophysiology is going into cellular structure. So cavioli, what is a cavioli? So cavioli are these minor nano indentations in the plasma membrane. And this is where we have our molecular clocks, the calcium clock and the membrane clock. And we know that disruptions in these clocks within the sinus node can cause issues. But what they found in this trial was if you have a certain degree of separation of the cavioli within the membrane between the calcium clock and the membrane clock, this seems to disrupt normal sinus node function. So what they did was they took out these mice, knockout mice, and they caused this cavioli caveole-3 mutation to occur. Now, what is caveole-3? This is responsible for setting up the scaffold of these indentations to occur. So when you take the scaffold away, separation occurs between the membrane and the calcium clock. So what they found was when you separate these small distances, there occurs a dysfunction in the sinus node. And they actually looked at the same model in patients who had heart failure, and they found similar results. So when you knock out the scaffolding of these caveoli and you have separation between the two clocks, it itself can result in dysfunction of the sinus node.
Okay, so it's not just a matter of fibrosis or cell channel down regulation. This is a microarchitectural problem that may account for sinus node dysfunction, and has certainly taught at least me a new term.
Right. And there's also a rare entity that we carry as, humans. They're not talking about mice here. It's the CAV3 mutation. I didn't realize it existed, but it does exist, and it affects the scaffold. And an interesting thing is that patients who have this mutation, they tend to die in their sleep because of profound bradycardia.
Interesting.
So I didn't realize there was a mutation.
Is that in a gene test, or is that something, is that in like an arrhythmia panel?
I'm not sure about whether it's in our arrhythmia panel, but it's definitely a mutation that's tested for.
Okay, rapid fire number 2. Alcohol consumption and incident A-Fib, meta-analysis, Europace. What do we know?
Right. So this is a trial that just came out in Europace, and it came out from Prash Sanders' group, and it's a really, really interesting meta-analysis. They actually took 26 observational studies, and with nearly 15 million people. So a really large-scale analysis. And, what they found in this analysis was a little bit disruptive, and we'll talk about that in a second. But what they did in this trial was they quantified alcohol consumption into different groups. And then they compared those groups with people who didn't drink. Now, again, remember, this is observational data. So they compared people in these trials that didn't drink versus different stratification. And what they found was not a linear relationship. This is one of the big things that came out in my mind. The way alcohol stood was if you had a small amount, it really didn't do anything. And then as you progressively drank more, there would be a linear relationship. But
right.
They found it was a J curve. So if you were drinking less than 12 grams of alcohol, which equates to about a drink or so, it may have actually reduced your incidence of A-Fib. So that was
So one shot of tequila, 14 grams of alcohol, to put it in perspective. So one shot a night might reduce incident A-Fib.
Well, that's what this observational data suggested.
Okay.
So we'll talk about that. What are the problems with this? And then when you went to between 12 and 48, it suggested that it may actually be helpful. Between 48 and 60, it was a wash. But if you had more than 60 grams, it clearly suggested that you were prone to develop atrial fibrillation.
So a clear uptick at that threshold of 60 grams, 4 or 5 shots, 4 or 5 drinks a night. That's a lot, even for we here in the U.S.
Right.
But Niraj, you're saying that this analysis, which has some really nice statistical advantages as well, you're saying that moderate alcohol may not increase A-Fib like we always think about.
Yeah, it may not. It may not. But there's a few limitations that we need to talk about. So the reference group, which is the abstainer group, may actually be dragging the risk to a different level. Maybe these abstainers are former drinkers. Maybe they are sick quitters. Maybe they drank and now they're sick and they're not drinking anymore. And maybe they stopped because, they felt sick, or there may be some mitigating factor that actually caused them to stop drinking. And then people who drink one drink a day may actually be healthy. They may have one drink and then go for a walk, right? So you got to look at these drinkers. Is there like an obese, diabetic, hypertensive patient who's taking a drink a day? Maybe that's not the right person that we should, tell them
all
to
of
continue
these,
drinking.
all of these covariates, someone that has a glass of wine a night, higher socioeconomic, better access to health care, maybe they exercise every day, et cetera, et cetera. Yeah. So that's really cool. I'm still calling it a win for someone that likes a glass of wine every now and then.
Yeah, I think it's, if you're healthy, yes, I would say that. And I would, still go with the current recommendations,
Right.
which is, if you have A-Fib, 3 drinks a week, but best to eliminate it if you have established AF.
Last trial. This is a brief communication for regarding a pulse self-exam for AF screening. Tell us about this one, Niraj.
This is one of the trials that we covered in Journal Watch, and it's actually a research letter. Usually research letters don't really make it, but I thought this research letter needed to be discussed. It's a very nicely done randomized trial and very cheap. What they did was they took patients who were at high risk for A-Fib, not established A-Fib, high risk for A-Fib, and they taught them by showing them a 90-second video of how to check your carotid pulse and how to check your radial pulse twice a day for at least 2 weeks. And what they found was there was a nearly a double detection of atrial fibrillation. So they went so in this group that was taught how to take their pulse, it was 5.9% versus 2.2%. So it really doubled the detection of A-Fib. But there's also this bias called the ascertainment bias. If you tell the group that, listen, you got to watch out for this problem and you're at high risk for developing, versus a group that you don't, people that have been taught to check, they actually would be watching out for symptoms and checking their pulses more often than the other group. So that truly can be a factor. And then what they did was they analyzed patients who had a smartwatch as well. And then they removed those people that had a smartwatch, and then the sensitivity even got better.
That's wonderful. Elegant in its simplicity. Ascertainment bias aside, you don't need an Apple Watch. I mean, I see global health implications for this.
Yeah, I do too. I mean, yeah, and of course, this doesn't take away our conventional monitoring that we do, but for a patient that does not have an A-Fib, or even a person who's had an ablation, right, has had an ablation and is not familiar with using, a lot of my patients, I'm pretty sure, Mike, you have that as well. A lot of our patients do have a smartwatch, but they don't know how to use it, right? They wear it and you have to educate them about using a smartwatch. And a lot of them, of course, don't have a smartwatch. So a quick little education about how to take your pulse can go a long way.
Well, as usual, Dr. Sharma, I feel educated. I want to thank you again for reviewing this in our monthly wrap-up. And Niraj Sharma, quick chance for a plug for your EP Edge.
So thank you, Mike, and a pleasure again to be participating. Just a reminder, the EP Edge Journal Watch newsletter comes out every week, and it's available on Substack, on LinkedIn, and it's accompanied by a podcast that goes over the same information, but in a audio format. So if you're driving and you don't have time to read, just listen to it on your commute, and we all have to commute a lot. Yeah.
You've been listening to the Heart Rhythm Society's monthly wrap-up in collaboration with the EP Edge. I'm Mike Lloyd for Digital Education. And we will see you next month. Thank you, Niraj.
All right. Take care, guys.